Could have another 2-hour panel discussion.
Yes.
But I think, can we have a quick rundown for the statements, the lessons we've learned that we should take home, because this is an educational meeting. Ezra, can you start?
Sure.
What is your summary?
I think from the comments from the audience and the comments from the panel, I think I would say three things. First, we cannot be dogmatic in our approach, and every patient really, as others have said, needs to be approached in an individual manner. Second, clearly, there are important questions that we need to answer in a prospective manner. There are very interesting retrospective data of selected patients, both from a surgical treated series and for chemotherapy radiation treated series. Clearly, different institutions are seeing different results, and there's obviously a positive, there's a bias in what people will publish. People will publish their positive results. So clearly we need to do more work. And then thirdly, I think long-term function is something that has been poorly addressed in past studies, and moving forward, it's something that needs to be incorporated in every trial we do in not only hypopharynx, but really every disease in the head and neck.
Dr. Ambrose?
Yeah, in the light of what we have heard about the complications and problems of chemoradiation, I would say from a surgical standpoint that we first should see whether primary surgical treatment, either partial resection or laryngectomy with partial pharyngectomy, is possible and feasible, and then go to, if this is not the case, then go to chemoradiation.
I would agree that we can't be dogmatic about choosing therapies. I would counter the comments from the Mayo Clinic by saying that we've all seen patients who've had bad outcomes with chemotherapy and radiation, and with surgery. And we can recount patients who had, bilateral neck dissections, partial glossectomies, and what we would term swollen head thereafter as a post-radiation treatment. So these are problems that we see in individual patients. What we need are programmatic scientific evaluations and research to give us that information. And I think I would urge my surgical colleagues to think in terms of protocols, of inclusion and exclusion criteria, rather than simply an experience. I agree, it takes 30 years to get a good surgeon. Or perhaps 10 if you're Dr. Singh. But an experience is extraordinarily important in these, but there's also data. So if we're curing 65% of patients or 75% of patients with induction chemotherapy and chemoradiotherapy, but only 35% with surgery in the hypopharynx, then I think we really have to reconsider the value of surgery and try and move the induction and chemoradiotherapy programs towards a better functional outcome. And I think one way to evaluate this is to ask the question, in at least the watershed and borderline patients, whether surgery has an impact versus radiation. I think we can do answer those questions. But that being said, I think we've made quite a bit of progress in the survival of patients. But remember again that when we put patients on chemotherapy trials, these patients are highly selected. You can read what the selection criteria are. You can select those patients yourself looking at those selection criteria, and you can see what we've done. And that's a very important part of how those trials are run. This is not somebody with coronary artery disease that had a myocardial infarction 4 months ago, or had pneumonia and was in the hospital for COPD 3 to 4 months ago. These are patients who are relatively healthy. Similarly, if we see a small tumor in the hypopharynx, with a skilled surgeon available, one might consider doing a partial laryngectomy and chemoradiotherapy, knowing that there's a high rate of local regional recurrence for those. So I think we have individualized therapy. I think it's important not to be dogmatic, and I think it's important to look at the data as we have it, and to understand the limitations of the data, the limitations of the way the studies are done, both the randomized trials as well as the personal experiential studies. Thank you.
Dr. Hitt, have you a last comment?
I think all options are possible. But for example, in my case, I think that induction chemotherapy plus chemoradiation is the best treatment. The problem is, it's not possible for all population of the patient with head and neck cancer. For the reason, sometimes surgery is the best treatment, or sometimes radiotherapy with cetuximab may be the best treatment. In my opinion, the important today is not only the organ preservation, The important is increase the overall survival. And with surgery and radiotherapy, the classical approach, overall survival is the same in the last 20 years. Maybe the change with the introduction of induction chemotherapy with new drugs and new type of the chemoradiation.
And with that, I would like Petra to have the last word. Petra?
Just one remark to your statement. The fact that a surgical procedure is difficult is not an excuse not to do the surgical procedure. A skull-based procedure is difficult as well.
Thank you.
Thank you very much.
I would like to thank my panel and the audience for their participation and Professor Connect.
Yes,
Thank
this
you.
is not an excuse.
Thank you. Well done. Well done. Well done. Very good.